So Indranil also joined. Okay, I think it's already 5:30 in Indian time. Let's have 5 minutes time. Yeah, five. Let's have 5 minutes time to introduce each other. And could you talk a bit about yourself? And hello.
Yes, sir. I think, am I
Yeah,
audible to everybody?
absolutely.
Yes, you are. Yeah.
Go ahead.
I'm a
Yes, are you
dentist,
audible?
specialized in oral diagnosis and radiology, and I've been into clinical practice for 18 years. And then I moved to US, University of Minnesota. Then after a lot of my work and being in public service, I found that there is necessary um, to make contributions in cancer policy. So I switched on to epidemiology in oral cancer and tobacco control. But I had no government-sponsored project of cancer screening. And I'm a representative from, I'm the health advisor for the Canterbury branch, United Nations. And yeah.
Wonderful. Yeah. We know that Dr. Shreyas just joined. He is working at. He's doing his MD in Tata Memorial Hospital, and
Oh, okay.
yeah, and I have a couple of close friends at Gujarat Cancer Research Institute, Dr. Kiran Kothari and Dr. Geeta Joshi. So
Yeah.
I have revived my contacts with Dr. Kiran Kothari. So it will be a good idea to, and he is actually basically head and neck surgeon. So,
Actually, I'm piloting a study, the first of its kind, which can give the government of India information of having a cancer screening program, because
yeah.
there's no evidence of population-based screening. I'm hoping that things would turn. That's
And the and the
Yeah, I am very much. I came to UK nearly 40 years ago, and I'm not an academic, but mainly clinician. And since I retired 3 years ago, I have taken up mainly doing Parkinson disease and movement disorder, and that's my exclusive interest at present in two large district general hospitals in South Wales, UK.
thank you. So our guest of honor today is Suptenda. Suptenda.
Hi everyone, I am Supten Sarbadhikari, essentially a physician from the same college as Dr. Arunalak Bhattacharya here, and I was hoping that Dr. Mikusina would also be joining. He's also from our college. In fact, I am exactly in between these two in terms of seniority or the batches. And after that, I've been into digital health for now more than 2 decades and a half, trying to establish the academic discipline of health informatics or medical informatics in India. I was with the Ministry of Health as the project director of the Center for Health Informatics for about 5 years. Currently, I'm an independent consultant for digital health. That's it.
Thank you, Suptenda. And then Ananna. Ananna, are you there?
Yes,
Yes,
yes, sir.
please.
Can you hear me?
Yeah,
Yes, we can.
loud
Yeah.
and clear.
Oh, I am still a student in the sense that I've just completed my DNB family medicine from Calcutta Apollo Gleneagles Hospital in 2018, and then I got a scholarship and I moved to UK to study MPH in global health at the University of Nottingham. I finished that last year, in fact, this year, and I'm at the moment doing some research. I'm working part-time with the University of Nottingham, teaching the students the new cohort now for global health, as well as I'm very interested in migration studies. So I'm working with London School of Economics. A division of London School of Economics is the London School of Migration Studies. So we are looking at policy recommendations worldwide about how migrants are being, integrated into a new place wherever they are approaching. So yes, I'm very honored to be here among all of you, and I hope I learn a lot today.
You not only learn, you also teach us something new. That that is all of us hoping for. Learn
Thank you, sir.
something.
I just wanted to add one more thing. Dr. Ananya, when she said, I'm doing a project on United Nations project on migration of Indian nurses abroad. So probably,
Okay.
it's a multinational from India to New Zealand, Australia, Gulf countries, and Singapore. So probably something of your interest, where if possible.
I'm actually sorry to interrupt. I actually have worked a lot with refugees. So 2017, when there was this extreme exodus of Rohingya refugees to Bangladesh, so I've worked with UNICEF India in the Kutupalang area, actually, with the refugees. So that's actually what brought my interest into working or finding out more or studying about the refugee situation. So when I mean migrants, I'm basically talking about the refugee situation around the world. That's what we are working on, to develop some policies, because there is no policies worldwide which is universal. So we're
Yeah.
just trying to see if we can develop some health policies for them.
So Aruna Lagda. Next I can see in the list Aruna Lagda.
I- I'm basically a medical pediatrician. I do pediatric practice. That's all. Do I
You want to
need?
hear more from you?
Do I need to add something? No, I do clinical practice. I am attached to some teaching institute in Kolkata, and I do my private practice, and that's all. And I have some vested interests in COVID situation. Shyam Babu will know.
Yeah.
That's
Okay. Vaishali. Vaishali, can you introduce yourself? Vaishali, everyone.
Yes, yes. Please wait.
Yeah. Yeah.
Hello?
Yeah. Hello. Yes. Hello.
Yes, can you hear me?
Yeah.
Yeah, we can.
Hello? Yeah. Yeah.
Yeah.
I am Vaishali. I'm a school teacher, and I missed Dr. Sarbadhikari's seminar at Macau, and it's a pleasure to hear him. And this topic, patients' rights, and it could be very useful, as we are quite ignorant of it. Thank you, and a patient listeners. I hope so.
We couldn't hear very much of it, but at least I understood. Okay. Devasmita, I'm almost like roll calling. Devasmita, are you here? Hello? Hello, Devasmita, are you there? Okay. Shreyash? Shreyash? Shreyash Choudhary?
Yes, I'm there.
Yes, I can see you. I see a big block there.
Yes.
Can you switch on your video?
Video. Okay, so I'll do that.
Yeah.
Yeah.
Yes. Yes. Yes.
So I'm basically MD anesthesia resident at the Tata Memorial Center in Mumbai, and I have an interest in developing critical care related services on a telemedicine platform. And I'm also trying to understand how we can improve our airway management practices using some digital tweaks or playing around with some AI stuff. But it's still something I'm working on right now.
Thank you, sir.
Thank you.
We have Shubham. Are you here? Shubham.
Yes, so I'm here. A very good evening to all panelists here. I'm still a UG student and I have got a lot to learn from all of you. I am presently holding some position in many medical organizations, like I'm local officer for sex and reproductive health, including HIV and AIDS at Medical Student Association of India. I am also holding a separate founder secretary position at Rotaract Club, which is daughter branch of International Rotaract Club, and I am presently the international certification course coordinator or bioethics, which is sponsored by UNESCO Education Department. So I'm still a UG student, and I have got a lot to learn from esteemed panelists and from all of you. So hoping to connect with you in future. Thank you so much.
Thank you, Shubham. Dr. Tamal Basu. Dr. Tamal Basu. Hello. Dr. Tamal Basu. Dr. Basu. And Indrajit, are you here? Okay. Indrajit also not there. Devanjali. No, Devasmita. Devasmita, are you here? Hello. Okay. I can find and let others join. Hello. Um, I can't see Devasmita, but can you? I will now start probably this session with a. Hello. 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 তুই স্লাইডগুলো লোড কর। হ্যাঁ, আচ্ছা আচ্ছা, ঠিক আছে 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 তুই তুই এটা অন কর। I'll have a short presentation for about 10 minutes, and I think after that I need to get into the bus, but and I will disconnect at the time. Dr. Raha will take care of it, but can
I hope you don't miss your bus.
no,
Okay, sir.
I'm sitting, and the bus is just
Okay.
come over there.
All right. We better get on. Yeah. Okay.
Yeah,
Everyone in the audience understands Bangla or not?
Not necessarily. Let's see. Acha. Where is Diptanjan Ganguly? Can you? Yes, Diptanjan. Can you load on this video or this slides?
We can see the slides.
Can you see the slides?
Yeah, I
can't
just saw it. Yeah.
Okay. Okay. I do not know how do I see that slide. I'm stuck at Shubham's place. Yeah, yes, yes. Now I can see. This today's webinar is on patient literacy and patient rights in India, and yeah, and uh, it is Dr. Supten Sarbadhikari. As you met him, he's the main speaker, and then Dr. Shandip Raha, who is a senior, very senior NHS consultant, and presently working in Parkinson's disease mainly. So I also invited him to discuss about patient rights in general. He can tell something, and then I, though I'm in the last, I thought I'll start talking in the first. So uh, next next slide. Yes, we Trinnect. Actually, I run a small telemedicine company in Finland. It's Trinnect Telemedicine, and we started something like 2013. And at the time, telemedicine was basically a video connection. Primarily, it started over uh, ISRO satellite links, and it was basically video communication between um, patient and doctors. We introduced first in India, I think, the personal health record based telemedicine platform, which, and my son is the free model in this picture in the extreme right. So this is, I think, the first time we introduced this kind of video plus PHR at the same screens in the same platform. That was our innovation, so called. Okay. And next slide. Right now, as of 2021, we both have a telemedicine platform, and we collaborate with Chandigarh Postgraduate Institute of Medical Research in developing platform. As well as we are also serving um, telemedicine services. We are providing telemedicine services. On our left side, we see 11 of our doctors who are associated with us. And some of them are here. For example, here you can see Dr. Runalok and Dr. Shesh. Indranil was supposed to be here. And on the right side, we have our faculties who already has spoken to our, who have spoken to our webinars. And we have specialties like general medicine, diabetes and cardiovascular care, dermatology, orthopedics, gynecology, pediatrics, geriatrics, and movement disorder, everything. We'll next slide, Victor. One issue which comes to my mind, that why we discuss patient literacy and patient rights. Yeah. This is my simplified depiction of uh, healthcare ecosystem. It's not everything, but it's a very simplified depiction. On the on the left side, there is a patient, some kind of a distressed face, and on the right side, there is a doctor as individual and hospital as a aggregated service provider. The fundamental assumption is that the patient has got no knowledge, and uh, all the all kinds of um, need for services, or all kinds of um, problems. And on the right side, we have doctors as a source of knowledge and services, and hospitals as a complex source of services, multiple services, complex procedures. And patients have, uh, while patients have the need for services, it's also, I mean, ideally, they have also uh, infinite amount of money, infinite amount of resources to compensate. And on the other hand, doctors and hospitals, they have infinite source of resources, infinite source of knowledge and services, and also infinite source of need for money or compensation. So in this ideal situation, there is everything fine, but uh, the conflict starts when these ideal conditions are relaxed. It's six, number six. Shyam Chakraborty 7. Okay. Just just a minute. I need to show the ticket. Yes, your appointment, Elisa, Nadia, Gmail. Just a minute. Yes, it's. Okay, thank you. 7. Okay, now we'll so when this this is relaxed, um, we have a conflict. And is this number 7? So and to solve conflicts, we need um, we need to have information. The more yeah, 7 places is upstairs. Upstairs, yes. Okay. Hold on, Seven, 8. Hello. Yep. So the major sources of knowledge are Ministry of Health and Family Affairs, and then World Health Organization, or CDC, Central, or PIMER, Chandigarh, etc. Or people can also ask Trinnect for information. we'll have a we'll have a full information services. We have a big network of people. We can have information as people want. Okay, next slide, Mido. Hello? Hello? Next slide. Okay, I think Shubtanda, you can start.
So are you leaving now or you'll be around?
Yeah, I'll be listening to this. I now leave it to you. I could get in my bus.
Oh, that's fine. So if you can see, actually, all of you, I mean, this is a document and maybe it can be shared with Tanjan. If you can continue the show, slideshow. Or... Thank you. So this is available from the public domain, and you can do a Google search on this patients' rights from the National Human Rights Commission, and you can download it. So there are 17 rights actually discussed in details. So can you come to the next slide, please, Diptanjan?
Diptanjan, can you put the next slide?
Yeah, it's visible now. As you can see on the very top, we have got what is called the right to information. And what Dr. Chakraborty has highlighted is in writing. So access to information, that is a big problem. And it's not a problem specific to India. I think anywhere getting appropriate access and adequate access to health information is a big challenge. And definitely, I mean, in the digital world, that is comparatively easier. The bigger problem which comes in.
Can you make it fuller screen? Diptanjan, can you make it? Can you? The slides are not coming. Diptanjan, can you put on the slides? Diptanjan, can you put the slides on?
It needs to be put on slideshow. It's on just slide view. It needs to be put on slideshow.
Can you, Diptanjan, put on the slides?
Slides are on, but they are not on the slideshow pattern.
Okay. What I'm doing in the chat box, I'm putting the link to this. Okay, in the chat box, all of you can see. I put the link to this. So each of you can actually download this document. You can go to this link which I posted in the chat box, and you can download that, and we can continue in this mode. There's no problem. So each of you, all the participants, you can straight away download this charter from the National Human Rights Commission site, and you can go through it at leisure, because here we'll be just going through it cursorily and we'll be talking more about. So if you see the 17 rights which are mentioned there, as I said, the first is the right to information, and to me that is of course the most important one. Then right to records and reports, right to emergency medical care, right to informed medical consent, right to confidentiality, human rights and privacy, right to second opinion, right to transparency in rates and care according to the prescribed rates wherever relevant. Can you come to the next slide, please? That's okay, Diptanjan. We don't need slide mode because I've given the link so everyone can download the whole document and go into it. Then next comes the right to non-discrimination, the right to safety and quality care according to standards, the right to choose alternate treatment options, right to choose source for medicine and tests, right to proper referral and transfer, which is free from perverse commercial influences. The next, again, a highlighted one by Dr. Chakraborty, right to protection for patients involved in clinical trials. Of course, there are ample safeguards available for that, but then of course there's always a gap between the lip and the sip, and so many implementation, like many other implementations, whether it's strictly followed or not, that's a question. So these are the 17 rights which are given in details, and so can you come to the next slide? Oh, that's when is the next webinar from Trinnect. So that's, I think, 1st March and end of March. Polycystic ovarian syndrome and cardiac care. Okay. So I think now we can remove the slideshow because, as I said, I've given the link to that. And everyone can download the document. Now, actually, I'd rather like to have it in an interactive way. And Dr. Raha, you can take over the moderation. Anyone of you has got any specific question related to any of these, I would be happy to interact. And let's make it more interactive because we have hardly 10 people here. So it's no need giving a didactic lecture. Over to you, Dr. Raha.
Yeah, thank you, Supten. I'm calling you just by first name because I don't know whether you're younger. I'm sure you're younger than me.
Yeah, most welcome.
Yeah, and yes, I mean, if people have questions, I have some question about those 17 rights, about how we go about making public aware of these rights, because I'm sure that millions of Indian population don't know about these rights, even those who are in upper middle class or in city dwellers. It may be useful for you to comment on this.
Yeah, that's actually a very good question. In fact, I mean, it's we Indians do have a lot of rights on paper. So if we look at, we have fundamental rights and various rights to this and that. What happens most of the times in practical terms, obviously, it doesn't really translate. So the way I look at it, the problem is mostly, I mean, in India, we are a population of 1.4 billion, and population itself is a huge scale, and time, therefore, disproportionately comes per head. The time for care services comes down a lot. So there are obviously various reasons and various facilitating factors in different places. In fact, if we go across India, India is not just a single country, so to say. It's really more of a subcontinent. So if you go across different states, you'll see different cultures. So in some states or some setups, you'll see the patients are treated well, even in government setup. Whereas in some places, even in private setup, they're not treated well. So that sort of a variation is there. Now, what is the recourse? Because whenever you give a right, I mean, obviously you can fight for it, and most of the rights are backed by some sort of a law. Now, if you go to the want to take the legal recourse for any violation of rights or unavailability of any of the rights, then of course you have to go to the courts of law. So since the late 80s, healthcare has come under the Consumer Protection Act. Of course, right now, specifically the term healthcare is not there, but indirectly, actually, it's still there, even in the newer versions, which is there in various different forms. Because the clinical, then there's the next act, which is the regulatory one, is Clinical Establishment Act. Now, in India, health is a state subject. So, if the central government promulgates the Clinical Establishment Act, as they did in 2010 with amendments in 2012, I mean, hardly 10 states, 11 states have taken it up so far. And states are legally free to do that. So they can have their own Clinical Establishment Act, or they may not have anything at all, whichever way they feel. So definitely it varies from state to state. One of the things which has happened, one of the good things really, so the byproduct is the digital disruption that this COVID-19 has brought forward. I mean, COVID-19 is actually called as the Chief Transformation Officer globally. And two sectors which have been massively affected are health and education. So this digital disruption has really been an irreversible one. So one of the things which happened in India, this telemedicine practice guidelines came out. And telemedicine is now legally supported in the sense that there is a formal notification in the Gazette for this telemedicine practice in India. Here again, what happened, one good thing which happened, in the telemedicine practice guidelines for the first time in India, any doctor who is registered with the State Medical Council or the Indian Medical Council can prescribe to any patient anywhere in India. So far, this was not really practiced because most of the states would insist that you have to register in our state to see patients in our state. But this telemedicine practice guidelines is the first one which has really done a great service in this way. So that way, I think they have also really supported the patient right. So patient anywhere can definitely take consultation with any expert anywhere in India. Of course, the telemedicine practice guidelines are for India only, so it doesn't go beyond the jurisdiction of India. And there are a lot of shortcomings as well, but then that's not the point. So any specific question as to rights, because as I said, I mean, even if you make someone aware of the rights, whether the rights will be available becomes so contextual, and the only recourse if the rights are violated is to go the legal way. That itself in India is so time consuming, and most of the time it becomes, I think, big problem for continuing with that.
Can you also clarify that whether the Healthcare Act is there is a bit of confusion whether it's only applicable to the state sector? Is it applicable in the same way in private sector? Because 70% of India's healthcare is provided by private sector.
No, I mean anything. It's as I said. Now it's under the service category. So consumers, in many ways, it's there. So it's laws are valid for all, private and government, everything. Of course, what happens in most of the laws, many times it's given. I mean, the term which we had read in our forensic medicine, the vicarious responsibility. The vicarious responsibility, usually the government has the least. I mean, that's how it becomes. Whereas if it's a private establishment, then obviously more heads roll, to say figuratively. And because in India, obviously, in the rural sector, I think more than 70%, and in the urban sector, it's more than 80%, it's private healthcare. In fact, if you look at the distribution of doctors also, there's often a talk that there's not enough doctors, which is not entirely true in the sense that the distribution is not proper. So you get more than 80% of doctors in 20 to 30% of the urban population, serving the urban population, whereas 70 to 80% people living in the rural area don't have access to more than 20% of this modern medical practitioners.
Thank you, Supten. Any other question from the people who have joined? Any particular question? I'm not very used to India's healthcare system at present, but yeah, carry on, Priya.
I just had a question. This may be
Yes, Priya, go
a
ahead.
little deviate thing, or I don't know if it is right, but I would like to know. We talk about the rights of the patients, and which is applicable to every Indian citizen. We know that there has been inequality in accessing to the doctors. Do rural patients have a right to demand that we need doctor as much as urban people? Do they have? Are there any such rights? Are there any such laws which provide rights to patients to demand the accessibility to healthcare?
I mean,
that's a very good question, Supten.
It's a very good question, definitely, and it's see, there's nothing specifically called for that. In fact, healthcare is not there even in our fundamental rights, so to say. But what happens is, I mean, whether they can demand that as a right, definitely they can demand, and you can see India is open to so many demands. So different sectors on different purposes at different times can come up with demands. So whether they can demand, the answer is obviously yes, they can. Whether they will get it, that's a different answer. Because as I said, it's ultimately the responsibility of the respective state government. So healthcare, if you go across India, in general, if you see the southern India, the southern states do offer a much better healthcare at a much lesser cost compared to the northern India. I mean, this is an established fact. So because it's a state subject, and also it's not the same characteristics. I mean, if you go through it, our genetic and environmental factors are also various. So, I mean, India is really a subcontinent. So different places react differently. So you can have one rule for all Indians, but whether it will be really available or not, that will really depend on that local culture. I'll give a very concrete example. Like, I mean, there's a tertiary hospital in Lucknow, that's the capital of Uttar Pradesh in North India. It's the Sanjay Gandhi Postgraduate Institute of Medical Sciences. It is a government setup, and Uttar Pradesh is one of the most densely populated states in India. It's quite big, quite densely populated. Yet, if you go to the reception, and this is my personal experience, I was quite surprised, pleasantly surprised to see that even if the patient party goes on asking the same question and again, instead of rebuking them, the person sitting at the reception is actually trying to explain it very nicely. Now, this is not something that comes from training. This is more what is, you can say, the Lucknowi tehzeeb, which is inbuilt. I mean, it's the particular different areas have different cultures, and so that makes a lot of difference.
So basically, we do not have a law which gives right to the patient to demand for accessibility.
No, there's nothing like that. And as I said, health is the state subject. Health is not a central subject. So in the Constitution of India, the state government still decides.
But India is moving into universal healthcare, and the Pradhan Mantri Ayushman Bharat, which is applicable to which is the central government has moved that all states should implement it. Whether they implement or not, it's up to the states.
Right.
Because some states are underperforming and some states are optimal, like Kerala and Karnataka, Tamil Nadu, where
some states are yet to sign up. There are still few states left which have not signed up for this Ayushman Bharat program because the financial model was 60-40. So state government has to pay 40% of the cost and central government will pay 60% of the cost. But there are a few states who have not signed. So I mean, as I said, it's ultimately the state's decision. Anything related to health, it's the state is the final authority.
Okay. Thank you, Dr.
Can I have a comment here?
Yeah, please.
Can I have a comment here? Yeah.
Yeah, carry on, Shyam.
Yeah. This is one the earlier observation of Suptenda is very pertinent that people can have demand, but it's a different thing if the demand is fulfilled or not. So it somehow it obscures the line of justifiable demand and unjustifiable demand. The borderline is obscured. That you can demand anything. Now you have to justify is it justified or no, it's not justified. You keep on tussling. I mean, this is a long run historical probably issue that and as people don't know that what is the justifiable demand and what is unjustifiable demand. Which demands cannot be justified. So people sometimes hesitate to demand something, and even if it is justified demand, then it's very easy to dribble it aside. That no, it's not justified demand. For example, the other things Supten pointed out is the lack of resources in India. The healthcare, healthcare provisioning is about 1.2% of the GDP. And for such a big country, and 1.2% of GDP is really paltry. Where in Finland, for example, it's about 7 to 8% of the GDP. So it's a huge difference. And even in that case, that some part of the money is returned because people there is a strong motivation of channeling the people to private healthcare. So if it is a government healthcare, often the facilities are unutilized and then or underutilized, then people are reluctant to buy new things. There's not enough doctors, not enough trained personnel who can operate the machines. They lie idle, so it's a vicious circle again. The only way of breaking the vicious circle is to increase the public healthcare spending. The only way, and then the rights are justified. It's a right for hunger, it's a right for healthcare, whatever be it. Unless then only when the infrastructure is built, then only you can say that yeah, the distribution of services is more smoother. Otherwise, only having a right doesn't mean much. You have to have the provisions, you have to have the instruments to deliver those rights. So that's what I wanted to say. Thank you.
Why my question came up was the government, of course, our GDP is 1.2 I mean our healthcare expenditure, public healthcare expenditure is 1.2%. But why I'm talking from the patient's perspective is at the sub centers and the primary health centers, the government has provided the doctors and the frontline health workers, but there has been more than 50 to 70% absenteeism. This is not one place or few doctors. Uh, uh, I think it was Harvard. I think it was a publication from Harvard because India is accessing enormous amount of international funds, and these are poured into the government sectors, not in the private sectors. The government sectors where the doctors have been appointed by the government, but the doctor is not available at the sub center or the primary health center. Then I feel the rights have to be given to the patients to seek that accessibility and make account. And because we have lost, but implementation is not there. So when patients are given such rights and awareness of those rights are created, I think this could be one of the branches of set writing the public health system.
I think this brings it to a very dicey situation. I'll respond to your question in a different way. First, I'll answer about the GDP part. USA spends nearly 18% of its GDP. The GDP of US itself is quite high, and 18% of that goes for healthcare. Despite that, they're ranked maybe 27th in healthcare. And if you look at it currently, I mean, they have got less than 6% of the global population, but COVID-related deaths has been more than 25% from US alone, globally. So GDP alone or money alone is not the problem.
Yeah.
And why is it so? So, like you said, rights. Patients are human, and so are healthcare providers. So, what happens for the rural posting? Most of the times, people don't join, or even if they join, they don't come because of the absence of various human rights in the
ডক্টর প্রিয়া সাগা যেটা বলছিলেন যে ডক্টরের ডিমান্ড করলে পাবো কিনা, ডক্টরসরা ওখানে জয়েন করছে কিনা, তার থেকেও বড় কথা যারা একটু অ্যাওয়ার, সবাই আমাদের প্রথমে কি জ্বর হয়েছে না সর্দি হয়েছে সেটা আমরা বুঝতে পারি, কিন্তু কেন হয়েছে সেটা জানতে চাই। বিশেষ করে ডাক্তারবাবুদের কাছ থেকে আমরা সেরকম ইনফরমেশন পাই না। হয়তো হতে পারে ওনাদের ওয়ার্কলোডটা খুব বেশি। তো আর এমনি যে ডক্টর আর পেশেন্ট যে কনফ্লিক্টের বিষয়টাও যে আসছে, ন্যাচারাল সবাই আমরা একটা আমাদের কাছে একটা ধারণাই থাকে যে ডাক্তাররা আমাদের কাছে ভগবান। তো সুতরাং পেশেন্টরা ভালো হয়ে গেলে কোনো জায়গা আসে না, কিন্তু যখনই কোনো দুর্ঘটনা হয়ে যাচ্ছে বা কিছু কিছু ক্ষেত্রে দেখা যায় ফ্যাটালিটি রেটটা না হলে পরেও একটা লং টার্মও পেশেন্টের ক্ষতি হয়ে যাচ্ছে। কিন্তু আমরা সাধারণত আমরা এই ইনফরমেশন গুলো যার জন্য আমরা কিন্তু সেই সংঘাতের দিকে যেতে চাই না। তো এবার আমি যখন এই ওয়েবিনারে আছি, এই আপনি লিঙ্কটা দিয়েছেন সেটা আমি ভালো করে পড়ে দেখবো, সেটা আমার জন্য ভীষণ ইনফরমেটিভ। কারণ আমি যখন কাউকে এই ওয়েবিনারের ওই আউটকামটা কাউকে বলতে যাব বা যে কোনো বিষয় সম্পর্কে আমি যদি নিজে ডিটেল না জানি তাহলে সেটা আমার পক্ষে বলাটা মুশকিল হয়, বা নিজের অ্যাওয়ারনেসটা ভীষণ ইম্পর্টেন্ট। কারণ নিজের স্বাস্থ্য থেকে শুরু করে আমার সারাউন্ডিংস, আমি প্রত্যেকবারই একটা কথা বলি যে সোশিও ইকোনমিক যে ব্যাপারটা রয়েছে, আমি এখন পাবলিক সেক্টরের দিকে, যেটা ইন্ডিয়ান পপুলেশনের আমি মেইন জিনিসটা লক্ষ্য করছি, আমরা কিন্তু হসপিটাল মুখ একদম হচ্ছি না। ঠিক আছে, হসপিটালে গেলে যে আমরা সার্ভিস পাবো না সেটা নয়, কিন্তু আমাদের মাইন্ডসেটটাই পাল্টে গেছে। আমরা খুব মানে ওই ইয়ের দিকে ঝুঁকে যাচ্ছি, মানে প্রাইভেট সেক্টরের দিকে আমরা ঝুঁকে যাচ্ছি। সেটা কেন হচ্ছে? আর এই যে ডিজিটাল হেলথ, এটা নিয়ে অ্যাওয়ারনেসটা ইম্পর্টেন্ট। আমি ট্রিনেক্টের সাথে যতদিন ধরে যুক্ত আছি, আমি দেখছি আমার ডকুমেন্টস গুলো কি করে আপলোডেড আছে। সেটার যতটা অ্যাওয়ারনেস দরকার সেটা আমি চাবো। তার থেকেও আমার কথাটা অনেকটা হলো, আমি পেশেন্ট লিটারেসি নিয়ে আপনার কাছ থেকে আরেকটু শুনতে চাই ওভারঅল সবকিছু মিলিয়ে।
না খুব ভালো প্রশ্ন করেছেন। So I'll switch back to English because we do have in the audience people who don't understand Bangla. So I'll just share my screen. I'll just show a slide.
I just wanted to have one comment that while talking of public health care, we shouldn't really mention US. US is a big aberration. This high expenditure versus low is the dependence on the private healthcare, on insurance-based healthcare, which has really spoiled over there. There's a lot of talks of COVID deaths in US going on. And so far I know that the COVID deaths in US have been primarily, probably 65% are above 85-year-old, and what is this called? This nursing home bound, and large part of them didn't get proper finances to get treated. That's what I understand, at least in US, from my friends in US. So,
Shyam, can you get Supten to come back on that original question, please?
Sure.
Supten.
Can all of you see my screen?
Yes, we can. Yeah.
Okay. So this is just a few definitions, but then I'd just like to the digital literacy. Obviously, we need to have digital literacy, which is, anything that is there, it's easy to say, easy to define, difficult to practice. But digital literacy is defined as the individual's ability to find, evaluate, and compose clear information through writing and other media on various digital platforms. So the biggest problem which comes here is to evaluate. There's a lot available on the net. Ask Google is very simple, but although Google does use a lot of artificial intelligence algorithms, but irrespective of that, whatever comes from the search, how do you really evaluate what you get? How authentic is that? And if you think in a condition like this COVID-19 pandemic, what happened? Even the knowledge was evolving. So what may be available today as the correct thing, tomorrow it may be overturned. And that has happened too many times with this novel coronavirus. So how to find information through the internet? And more important than that is how to really authenticate it, whether find that evaluation is really trustworthy. So that trust part is very important. Then the next important related one is called the data literacy. Data literacy is also similarly defined ability to collect, manage, evaluate, and apply data in a critical manner. The keyword here is critical. That means any data, whatever is there, doesn't necessarily mean that is correct. So, like MIT and Emerson University, they have defined this data literacy as the ability to read, work with, analyze, and argue with data. It's arguing or critically evaluating, that's important. So when it comes to health data, we call about health data literacy. Now, this digital literacy and health data literacy together, it's called digital health literacy. So I think this digital health literacy is something that needs to be encouraged. The awareness needs to be spread. So when I talk about spreading this digital health literacy, it's not just for the patients, even for the doctors. Because now what is happening with the digital literate patients, or persons, especially in the urban setup, and even now in the rural setup, we are having lots of these wearables, the Fitbits, the Apple Watch, and this and that. So all these various wearable devices which are collecting health data at home during activities round the clock. A patient comes to a doctor, he or she would expect the doctor to manage the condition using this data which has been collected round the clock. And that is huge data. Human brain, however great it may be, it is limited in its ability to crunch data or to analyze a huge amount of data, and especially if they're not directly connected. So that is where this understanding what data is required. It's important not just for the patient, also for the healthcare provider. So that, in fact, when we are talking about digital health is really building a cooperation, a trustworthy cooperation between the patient and the healthcare provider in such a way that the health outcomes are improved.
Thank you, Supten, for that. Any other question from other participants?
So, Vaishali, does this answer your question? I mean, about literacy you asked. So we need to make everyone literate, not just the patients, but also the doctors.
একদম ঠিক একদম ঠিক থ্যাংক ইউ
I mean, I have got a point to make if Supten can answer that.
Go ahead, please.
I think the way to before we even go to digital medicine and digital literacy and digital health data, at the same time, maybe in parallel, the media in India has to bring health at the forefront rather than politics at the forefront. I think that needs to be done. Without that, I think a mass population is not going to understand implications.
Yes, that is definitely a very important point. In fact, Ayushman, because health has never been also in the what we call the political manifestos for any elections, either in state or the national level for any political party. But this Ayushman Bharat has definitely changed that thing, and now we have got the National Digital Health Mission. So it started on 15th August with 6 union territories, and now, in fact, it has been rolled all over India. It is being rolled out since January. It is being rolled out all over India. So National Digital Health Mission does have a big component of this. In fact, National Digital Health Mission is part of this Ayushman Bharat. And Ayushman Bharat, there are two parts. One is the UHC, the insurance-based payment for the treatment done even in private hospitals. The other part is the health and wellness centers. So 150,000 primary health centers and community health centers across India are set up with this health and wellness centers, and there also telemedicine is being practiced in a big way. The e-Sanjeevani PHR and OPD platform has been launched. It is being scaled up. It's being used. In fact, I think they have already crossed 1 million consultations through that. But of course, it's a great beginning. It's a very long way to go, but I think the beginning has been made, because in a huge, vast country like India, we cannot think of having infrastructure, physical infrastructure. We cannot think of having a medical college in every district. But definitely through digital health interventions, we can increase the access, availability, and reduce the health inequities.
I have a few comments. Uh, Firstly, I mean, Ayushman Bharat has a. I mean, I do not want to criticize a government scheme, but since it's a more personal group, that it channelizes the money to private sector, and that is an impediment of developing real research oriented. There is practically no private sector in India which is doing any research in healthcare. So that is one thing. Second thing is that you cannot really, until there is a quality control, there is an audit, you cannot really implement such a scheme. So the first thing is that there should be a quality control, and again it comes to this patient rights, how this patient rights would be implemented, and the instruments of implementation that has to be there. So in that way, and of course, yes, this is Sanjeevani and everything. People are getting benefited. I'm very hopeful about that. But about the Ayushman work, surely I'm not very. I think the money would have been much better spent if public health care facility would be infrastructure would be uh, strengthened in that way, which hasn't been. In fact, public healthcare infrastructure has been ricketted. I mean, has been more rickety compared to the population growth.
Yes, this public health infrastructure, that's a very important point. Definitely, and it has been seen during this COVID-19 pandemic that it's not India alone. I mean, globally, the public health infrastructure has come under severe stress, and in fact, nowhere has it been found to be adequate, however developed or economically advanced the country have been. So the good thing about this is in the current budget, the budget which has been recently presented in India, there has been 127% increase in the allocation of the health budget. And also there has been a lot of additional money poured in for supporting various things, including infrastructure. But infrastructure, the physical infrastructure is one part. The other part is the human infrastructure. So even if we have AIMS in every state and IIT in every state, there may not be enough faculty. That again is a problem. That is an ongoing problem. And so it's really a multi-pronged problem. It's not a single solution that you just pour in a lot of money and everything comes in place. It's not going to happen. So policy, governance, intent, all these things together only can make it. But as I said, I mean, this COVID-19 has been the greatest digital disruptor, and health and education have been the two sectors which have been affected globally. And India in particular, definitely in this, definitely the health allocation has been increased quite substantially. And of course, just having money, as I repeat, it's not enough. So how well it is implemented, that we have to wait and watch.
Supten, there is a question from Priya about can you give a few more details about Ayushman program?
Yeah, exactly. I mean, what do you want to know, Priya?
Priya?
How aware are people about How has any effort been made to bring about awareness of Ayushman Bharat and for people to utilize the provisions under Ayushman Bharat? Because
Okay,
being
I'll
in
come
the
into that. Yeah.
health sector we know, but have public been sensitized about existence of such a program?
Right. Right. Yeah. So before answering that question, I'll another part I left with Dr. Chakraborty said about this quality control. So again, another thing which has happened, there are definitely medical devices. For medical devices, so far, I mean, most of them were not under any control, but there has been a medical devices regulations 2017, which has now been amended. It's now the medical devices amendment rules 2020, where all medical devices have been termed as a drug. So they will now have to go a quality control as for all drugs. So of course it's started right now. So there are timelines given. So till August 21, August 22, August 23, different categories of the health devices have to have anyone whoever is developing or importing those health devices, they need to have some certification. So far it was not there. So quality control, at least for medical devices, is something which has started. In fact, price control, quality control, those things are there. Coming back to Ayushman Bharat, yes, people, because it has been started initially only for the BPL, the below poverty line card holders, and they have been fairly aware because it is one of the very successfully implemented programs of the government of India in recent years, and people have been using it. In fact, the amount of claims made and settled is enormous, and it's a huge number in terms of people and money both. So yes, people are already aware because it has been widely publicized. The only problem is, as I said, many of the states have not accepted it. So in the states where they have not accepted it, it doesn't work. So that's a political problem, really, rather than this. But now they are also planning to bring it for above poverty level people. So maybe the premium mode would be this: you have to pay some nominal premium because government alone may not be able to do that. So Ayushman Bharat as a program, when it's talking about insurance coverage, it's good. It is serving its purpose. But that's not the question. I mean, is it improving the health outcomes? Health outcomes is not in the mandate of the Ayushman Bharat, this PMJ program. So for that, as I said, health and wellness centers is the other arm. And then, of course, strengthening the existing infrastructure, that itself is very important.
One of the things is that you mentioned developing infrastructure in terms of developing IITs and IIMs. That is a bit top-heavy approach. Basically, what is needed to develop the rural healthcare, the basic primary healthcare, and the infrastructure needed for that. So, for example, somebody, say, for example, where Bushali lives in Kujbihar district. No, there is a government college in Kujbihar in this Kujbihar district, new government college, but until unless you have a full infrastructure over there, say schools and colleges and everything, people are reluctant to go and stay over there and run their business. I know that from Shiliguri Medical College, there is a there is a severe kidney severe what is it called this chronic kidney disease severely affected person who took out this girl from the Shiliguri Medical College and shifted it to a private institution in Hyderabad. Though the treatment was free in Shiliguri Medical College, they couldn't rely on it. Just because there is no doctor, there is no provisions. The, so it's not only developing IITs and IIMs, it's also developing the basic infrastructure.
working. So in fact, quite a few have come into light, and they're checks the biggest health outcomes. But I think if they could just link health outcomes with it, I think the program would really serve much more than the purpose it's serving right now. Practice guidelines are notified, and I'm again sharing my screen.
Is this the one only valid in India? Yeah.
So can you see my screen?
Not yet. I can't see it yet. Yeah. Now it's coming, I think.
Okay.
Yeah, we can see it now.
This is the sample prescription format that's given in this. This is how it should look like. And again, unfortunately, I'm not sure how many are really practicing this. So the registered medical practitioner's name, qualification, registration number, address, contact details have to be there on the top. Then the patient details. It's not available, but just a provision must be mentioned. This is a mandatory part. So diagnosis must be mentioned. Any prescription which does not have the diagnosis mentioned is not acceptable. Then the chief complaints, the relevant points from history, findings, lab findings, suggested investigation, these would be there. And for the medicine part, name of medicine in capital letters with generic name. So name of medicine in capital letters with generic name, drug form, strength, frequency of administration, and duration. So all these things have to be clearly written. And of course, if any special instructions are there, it has to be signed, signature and stamp of the doctor has to be there. So for any telemedicine consultation, a prescription has to be like this. And I repeat, the most important part is if it does not contain a diagnosis, at least a provisional diagnosis, that will not be accepted by the court of law. So this, I think, is something, and I think Dr. Chakraborty would like to share the prescription format, or I'll go ahead, please.
Yes, I mean, is this all over India or only the states who have accepted Ayushman program?
No, this is a part of telemedicine practice guidelines, which is actually they've amended the Indian Medical Council Act. Within that, the Codes and Ethics Regulation 2002. Now it's 2020. So this is for any prescription